Hello, this is Clark Simpson. I'm very happy to join you today to talk to you about ethics in coding and billing and concerning the third-party billing of athletic training services. As we get started, I do have some disclosures that I need to make you aware of. As I said, I am President and CEO of the Clark Group Associates. The Clark Group is a consulting firm that works in the sports medicine athletic training space. We work with national associations, as you can see here on this slide. The National Athletic Trainers Association is one of the organizations that we've worked with. We've worked with multiple state athletic trainer associations across the country, as well as numerous collegiate university sports medicine programs. So we work with the business aspects of sports medicine. So in all of these instances, whether it's business strategy or billing, coding issues, and the answering the questions, is this the right thing to do for us? And if it is, how do we go about doing that? And those kind of things are some of the work that we've done. So we do business assessments, and then we do project management for those institutions that want to move forward and do that. So today we want to talk about ethics in coding and billing, and this is something that is definitely very interesting to me, and it's something that myself and my company works with a lot and does a lot with. It's really important in the athletic training space, especially, to talk about this ethics of coding and billing, because we as the athletic training profession is new to the game in billing. And so it's not something that most athletic trainers have gotten a lot of specific training on and understanding. If they are doing it or involved with that, it's training they've gotten from other institutions or programs or that sort of thing. And for the high-level profession of athletic training, it's very important for us to maintain a high ethical standard as we're going into the billing of services to third-party payers. So the ethics of coding and billing is very important and really kind of is setting a tone for, as insurance companies and employers and et cetera get to know us and learning about that we're doing it right and doing it ethically. So the learning objectives for this presentation, as you can see here, wanting to understand medically necessary treatment. What is that? And we'll talk quite a bit about medically necessary treatment. We want to talk about the 8-minute rule that Medicare has as far as coding for the processes and procedures that we do. And we're also going to make sure that we discuss different methodologies for how you or your company would actually set your fee schedule for an athletic training service. So ethics, what is that? Everyone may have their own idea or opinion or definition, but this is, the NATA has a position statement on that, and basically states athletic trainers or ATs should conduct themselves as honest, responsible healthcare professionals. This is a statement that we just should know, take to heart, and be comfortable with. What that means is that we're knowledgeable about relevant laws, that we conduct ourselves in a professional manner and follow professional ethical standards, and that we practice sound business practices. So again, this is a position statement and comes from a position statement that I've listed here from the NATA, and this is ethics in general. So in our clinical practice and how we treat others and work professionally with others. But as we go into kind of this new sphere of billing third-party payers and working with insurance companies is to make sure that we are doing things properly, ethically, and really not trying to cut corners, because if that occurs, and I think all of us probably have read in the paper of medical systems or physicians or other healthcare professionals that have cut corners, they've billed or coded incorrectly, whether knowingly or unknowingly, for millions of dollars at times. And so that is not where we want or need the professional athletic training to go right now. We need to maintain our ethical standards and be able to demonstrate to the industry that we know what we're doing and we're going to do it properly. So we're going to start with medically necessary. What is that? Hopefully this is not a new term, to you or not, but the definition I've got here: ATs perform clinical therapy, should only bill the third-party or third-party insurance providers for services that are medically necessary and relevant to the diagnosis by the provider. So I can read that, and you can see that and think about that and mull that over, and you can go, okay, so why? Who's setting the rules for that? Who says that I have to bill medically necessary and what's relevant to the diagnosis? Well, who is saying that is the insurance companies. It is their business. They are setting the standards, if you will, for what they pay for. So the insurance companies, are the payers that are setting these policies and procedures. They, put out the significant definitions of, okay, this is appropriate, this is what we'll pay for, and go into significant detail, if you will, on what qualifies for payment. Insurance companies are business companies. Let's never forget that. They are in the business to make money. So if we do not follow their policy procedures, we do not follow the rules that they set out, then, and they find that out, then they will not pay for the services that we're asking to be paid for. So they're setting the rules, if you will, on that, and it's quite fair. It's not against the law. It is their business, and that is how they've set that up. So we need to understand that as we're moving into this business of billing. So what is this definition? What I've kind of laid out here for you all to look at is really a composite of, from multiple different companies, from Blue Cross Blue Shield, Aetna, and that sort of thing. As I looked at their definitions of what they consider medical necessity and what they pay for, and any of you can go out and Google, use your search engines to just look for medically necessary in any of the insurance. You will very easily find definitions that they've got. So here's kind of a composite definition. That medically necessary, it has to be in accordance with the generally accepted standards of medical practice. So what is that? Well, it's standards that are based on credible scientific evidence, evidence-based practice that we all are working very hard in the athletic training profession to follow. Along with that generally accepted standards of medical practice, that is followed by, the particular physician specialty society or other qualified healthcare professionals. So, any of the family practice, primary care societies, orthopedic, physical medicine and rehab. So any of the specialty societies and the standards there, they set, following that, and following the peer-reviewed literature and evidence-based practice they do, as well as any research that's been done in the rehabilitation realm. So it's following, that evidence and the views of physicians and other qualified healthcare professionals practicing in that area. and it follows, from a clinically appropriate treatment. So you can't just guess. You can't just go in and do things. And again, everyone hearing my voice and following this presentation knows that. We have a lot of emphasis in our profession on evidence-based practice, and do that, following, the aspects that I have on this slide, as far as what type of treatment, how often are we doing that treatment, the extent, the site duration, and the effect on the patient's illness, injury, or disease. So there has to be reason and evidence for the treatment that we're giving them. We can't just give something that we want to, bill it, and just feel like that's going to get paid for. So that's the definition of medically necessary. That, when you take that versus what are not medically necessary. Non-medically necessary obviously falls out of that definition, but if you think about what we as athletic trainers are doing in the athletic training room, and let's look at our secondary school collegiate athletic training rooms and the work that we're doing there. We're doing a lot of education, we're doing a lot of prevention, we're doing a lot of maintenance, we're doing a lot of performance enhancement type of work. We're doing maybe a lot of supervision and setting our athletes up on programs that they are doing, and we're just observing what they're doing. All of those aspects fall out of the medically necessary realm. Those do not meet definition. My experience, and this is my personal experience that I've had in the consulting that I've done and the work with collegiate programs and secondary school programs, is that probably between 20 and 25% is about the percentage of what would be considered medically necessary services that we're doing in the athletic training room. And again, that's an average. There would be some training rooms that would be a higher percentage, some that would be lower. But if you think about what we're doing, obviously the prophylactic work that we're doing and the taping and bracing and that sort of thing is not meeting the medically necessary unless there is an injury that we are providing bracing for in the DME aspect. So I wanted to clarify that because there's a lot of questions about medically necessary and what should we bill for. And I have worked with a lot of groups that they really just kind of bill for everything that comes through the athletic training room door, and that really isn't appropriate. There are policies, there are standards, there are definitions for that, and we've just gone over that. So, what also falls into medically necessary when billing for insurance? Well, the Clark Group definitely believes, when we're working with our clients, that to bill an insurance company, you really need a prescription from the qualified healthcare provider in your state that you're licensed under per your state license. I know, that athletic trainers are capable of seeing patients and treating patients under a standard standing order. And those stipulations and that criteria changes from state to state on how it's written. But all of us work under the collaboration, the supervision of a licensed healthcare professional, usually a physician, in doing that. However, when we're billing third-party payers, and that's what we're talking about here, that if we would ever go through an issue where the insurance company is asking any questions or et cetera, they're going to want a specific prescription to be able to look, and that a medical provider has seen this individual or has made the decision to refer them for rehabilitation. So we know in this day and age that we deal with very few written or paper prescriptions. So this is probably going to be a dictation from our electronic medical record and meeting those standards. So it's important that we have these prescriptions for services provided. That can sound like it can take a lot of time, but having worked in clinics myself, in multiple hospital situations, working with PT, OT, speech, as well as athletic training, doing this, you can get those prescriptions and should be able to move through that fairly quickly. So it may be different and foreign, certainly to the athletic trainer that's never done that, but once you get a system down, it is not that laborious to do that. Now, along with talking about that prescription, we also need to know that we need to have a prescription that is for us, for the athletic training services. So I've listed some here that that it can be for athletic training or physical medicine and rehab or sports medicine or just therapy. All of those fit within our scope of practice and what we're doing, and a prescription for that would work. What we cannot do is we cannot work under the prescription for services like PT, OT, chiropractic, or other healthcare professionals. So the prescription needs to be for us and for what is within our scope of practice. And of course, that is, assuming that you're not dual credentialed and that you are not also a physical therapist, an occupational therapist, or a chiropractor. Obviously, if you're dual credentialed, then you would be able to work with those prescriptions as well. So this is important to understand, and this comes from my consulting that I've worked with different systems that at times I have had athletic trainers treating under a physical therapy script. And if that ever was audited or found out, that could be a very, very negative thing. Also, when we're talking about, medically necessary, on the prescription that we receive, we need to have the healthcare provider that is giving us this prescription or sending this prescription to us, that they are giving us the diagnosis code, the ICD-10 code for the problem that they are sending to us. Athletic trainers, it is not within our scope of practice to diagnose injuries. Now, oftentimes we do that, and we're consulting with our physicians, and we're telling our physicians, hey, we believe this or that. We've done the testing, and we believe there's an impingement syndrome here, and that sort of thing. But the physician must be the final say on that, and they are the ones that must diagnose the injury or the illness. So athletic trainers should not be picking the ICD-10 diagnosis code. That should be something that comes with the prescription, and again, that may be in the electronic medical record, or if you get written prescriptions on that. If you do not have that, it's very easy to contact the medical office and ask them for, what is the ICD-10 for this script that you sent over. You need to get that from them. Do not pick that out yourself. So that kind of covers the medical necessity aspect that I wanted to talk about. So again, very quickly, we want to make sure that we're billing for the correct services, things that qualify as appropriate services that insurance companies have set the rules and guidelines that can be billed for. We're wanting to make sure that we're getting a prescription for that, and the prescription is for us as athletic trainers, and that all that is well documented, in the medical record and what we've gotten. Scope of practice. So from the ethics standpoint, we really need to be aware of what our scope of practice is in the state in which you're practicing. I don't know how many athletic trainers that I've talked to in my consulting realm and received calls asking about billing, and they tell me who they are and what state they're at and what setting that they're working in, et cetera, and want to talk about billing. And I ask about their Practice Act if I haven't already done my homework and looked at it, and ask them about their Practice Act. And a very high percentage of athletic trainers do not know what their license in that state allows them to do or not to do. So know that. It's very important for you as a professional to be aware of your license. What does it say? Or what does it not say? Again, it's your lifeline. It is your livelihood. You need to know that. So know it, understand it, be compliant with it. I put the NATA link that they have that really gives a link to all 50 states, and you can be able to select your state and be able to go out to, pick out the Practice Act and be able to get that. So very important. Understand, what your scope of practice, what your Practice Act in your state does tell you. Documentation. Something that, I don't know any medical professional, not just athletic trainers, but any medical professional gets very frustrated talking about documentation. No healthcare provider went into this profession, no matter whether it's physician or rehab or whatever it may be, to do paperwork. But it is a necessary evil. It is something that we have to do. And we have to do that as professionals outside of the third-party reimbursement realm that we're talking about. But when we're talking about third-party reimbursement and requesting reimbursement or payment for services that we're providing, documentation is just highly important, because that is what we're being graded against. So if we do not document well, and if information is not put in properly, that is telling other people we didn't do it. So the SOAP aspect that we have up here is very familiar to everyone. That is a standard format that we talk about. What we run into a lot is not doing a good job with actually our plans and being able to lay those plans out. So work on that. Most everybody has heard of the SMART goals that we do, but we aren't always real good about following those. So our plan and our treatment has to be specific, for what we're treating, has to be measurable, has to be really achievable. Okay, so we can't do that. We have to have realistic timelines. So we just can't say, though, that something that would normally take 3 months, we're going to get done in 2 weeks. So it has to have realistic guidelines and appropriate from a timely aspect. So understanding the SMART goals, having these out, and being able to write to this. The documentation can definitely be helped by a good electronic medical record program that has got templates, and you're able to go through and do this. So I can't emphasize enough the importance of documentation. It is probably the number one, it's not probably, it is the number one issue that I have had brought up to me by employers especially in health systems, in physician practices, in private practice groups. When I worked with the NATA as the National Manager of Strategic Business Development, and I took calls about athletic trainers and the business of athletic training, the number one issue that all of these employers had about athletic trainers was documentation. That was really probably the only negative that they tended to have, was that the athletic trainers just did not tend to document to the level they needed, and they really had to have extra training. So from our standpoint, when we're talking about the ethics of billing, it's very important that we get this down, that we work through the, be able to work through the process, if you will, and smooth out the bumps in the road to be able to get it done efficiently, because without a doubt, it takes time and is going to add some time. Look for your systems to help you to be able to reduce this. As we're talking about documentation, the coding and billing, that we're doing, and again, I think I emphasized this, a little bit earlier, but, if it's not documented, it's not done. And so, if we haven't got everything in there about, that we're working with a right arm or a right upper extremity or right shoulder, and what the treatment is that we're doing it, how long we're doing that treatment, that is quite often not put in there. But I will tell you that you routinely, from the physical therapy realm, you either have to put the number of minutes or the time started and time stopped on procedures. But you've got to be able to account for the amount of time, because the majority of these codes are time codes. And so we cannot be judged by time if we have not documented the time we've utilized. The other thing that I've shown here is, and it was also discussed in medically necessary, is appropriate time. So you can't work on a tennis elbow for 2 hours or even an hour. To be able to concentrate specifically on that area for that long a time, no matter what you're doing, is going to be too extensive. So it's going to need to be appropriate. Whether yes, you may be doing augmented soft tissue mobilization or other manual therapy, or you doing different modalities, and those can add up to where we're doing that, but has to be an appropriate amount of time, and it has to be demonstrated and documented in that way. HIPAA. The Patient Privacy Act, when we're talking about ethical aspects, this is ethical issues, but it's, from a legal standpoint, there are people within systems that have lost their jobs because of violation of HIPAA standards. So understand what those HIPAA standards are. I'm not going to try to possibly cover all of them, but patient information must be confidential. And in our athletic training rooms, even in our clinics and that sort of thing, and it's easier in our clinics than it is in our athletic training room, but we must be careful about the patient privacy, what's being done, how it's being done to a great extent. So maintain that confidentiality. As far as billing coding specialists, and as a healthcare provider, we have to anticipate the issues and threats and do whatever we can to prevent threats that allow patient information, private patient information, to be able to get out. So I have included a link to the HIPAA website to be able to look at this. But privacy concerns, patient privacy concerns, are extremely important, and something that has to be planned for and worked through and set up policies wise to work around. So we talked about ICD-10 codes previously. ICD-10 codes are diagnosis codes that the referring physician are going to be sending to us. CPT codes are the procedural codes. That is what we're doing. So those codes are the codes that we utilize, and we get to determine, appropriately what codes to supply. So they describe the procedures and services. CPT codes are just descriptors. Oftentimes people kind of get confused, and it's about money and it's billing and that sort of thing. It's really not. The American Medical Association, who owns, runs, manages CPT codes, are very adamant that CPT codes are descriptive codes. They are describing the services or procedures that are being done. And so it is not about the dollars. It is about the you need to follow the codes that are specifically describing what you're doing. So, you see the notation I've got. You do not select a CPT code based on reimbursement. This happens frequently. I've been exposed to it on many, many different occasions. I'm sure many of you that are on here may have as well. But when we're, from an ethical standpoint, we need to be aware of that we're selecting CPT codes that describe what we're doing. We're not trying to manipulate the system and be able to code strictly for reimbursement. The other thing that's really important for athletic trainers to be aware of, and this is misunderstood, it's almost a myth that is out there in the billers, coders, and the healthcare realm, and that is CPT codes are not profession specific. Kind of goes back to what I've been kind of beating the drum here with, that they're descriptive codes. So as long as you, the athletic trainer, are working within your scope of practice, under your license in your state, you have the appropriate training, and you are treating treating the appropriate treating the appropriate procedure or service, then, and that falls within your scope of practice, then it's appropriate, and you can utilize that. Quite often, I've had billers and coders that are professional in doing this have stated that the PM&R codes, the physical medicine rehab codes that are the 9700 series, are physical therapy codes. Well, that's just not correct. Physical therapy is the high utilizer of these codes, but those codes are for any healthcare professional: PT, OT, AT, massage therapy, chiropractors, physicians, PM&R docs, osteopaths, naturopaths. All of those individuals qualify to utilize the PM&R 9700 series codes if they are doing those procedures. So I'll get off that soapbox, but that's something that we certainly need to be aware of. Coding for service, here is following Medicare guidelines and rules and regs. This is something that not only I feel professionally and Clark Group Associates, when we do consulting and make these recommendations, it's something that the NATA and has position papers to follow when billing, following Medicare guidelines, because Medicare is the gold standard. Their guidelines is the medical industry gold standard. They've done the research. They've got the backing with this. If we want recognition, then we should follow the gold standard to do that, right? I mean, that is, if we're going to be the highest ethical standards in doing that, then we should follow the highest standard. And I will tell you from consulting in multiple states across the country that the majority of commercial health insurance companies follow Medicare guidelines. Now, I will preface that, or follow that up, not preface it, with the statement that that's not 100%. There are companies, and they are business, and they have a right to set up their own policy and follow their own policies. However, I will tell you that the most of the large companies, the big five companies, the Blue Cross Blue Shield, United Healthcare, Aetna, Humana, Cigna, they, for the most part, follow Medicare guidelines from billing standards as well as coding and that sort of thing. So just know that. And I've got it kind of bolded at the bottom. If you are Medicare compliant, you are virtually compliant with everybody. So just follow that. I often hear, and again, I'm probably on my soapbox again with this, but I hear this frequently from athletic trainers or from vendors that work with athletic trainers on this, that we're not billing Medicare. You're not going to be doing that. And you're not recognizing Medicare, so why are you following your guidelines? Well, I hope the things I've just gone over will convince you that, yes, it is appropriate to do this, because for the most of the industry is following it, and it is the highest standards. So that's where we want to be. Medicare has set some rules, if you will, for billing codes. As I've stated before, many of the CPT codes are time codes. Almost all of them are 15-minute codes. There are a couple that are 30-minute codes, but for a majority, they're 15-minute codes. Well, so when can you bill for them? I mean, that would be a question if you came into it and didn't have any idea. You've got a 15-minute code, and so if I only do 13, can I bill 15? Or if I do 20, can I bill 2, and that sort of thing. Well, CMS or Medicare has set up a rounding table, and it's called the 8-minute rule. And so this is the 8-minute rule that I've demonstrated for you here and have given you a chart that can follow. Is that in order to bill 1 unit of 15-minute therapy, you have to do a minimum of 8 minutes of one-to-one therapy time, a minimum of 8 minutes up through 22 minutes. Okay, so between 8 and 22, you bill 1 unit. If it's less than 8 minutes, then you can't bill for that. You didn't do enough. If you are doing, and let's say it's therapeutic exercise, more than 22 minutes, you get into 23 minutes. From 23 to 37 minutes, you can bill for 2 units of that time. So 8-minute rule, minimum of 8 minutes, and then really, if you look at that, then it's just taking 8 minutes and adding on to 15. So 8 minutes up to, then it's 8 plus 15 is the 23. You'd have 30 plus 8 would be the 38, and so forth. So the 8-minute rule is what we need to follow as you go through that. And the documentation is that you need to have the start and stop time when you've done the procedures, or the total amount of minutes. These need to be documented, as we've talked about, in your medical record. So that's coding. Those are the CPT codes and coding. And just to go over that again, CPT codes are our procedural codes. That's what we do. We're going to utilize those codes that describe exactly what we've done. We're only going to do codes that are within our scope of practice. And when we're doing time codes, we are going to follow the 8-minute rule on how much we're able to bill, how many units of therapy we're able to bill with that. So that's CPT codes, billing. Claim submission forms. There are a number of different forms used for or by different groups, institutions. So I wanted to kind of make sure that you all are familiar with these. And again, this is an ethics course and talking about it, and it's about doing it right. So if you do it wrong and you send and bill send somebody who takes UB04 a CMS 1500 form, they just would pay you, so there's nothing unethical about it. So this is probably more about business than ethics, but let's talk about that. So these are the three different ways that you would actually be able to bill and be able to utilize and put on the ICD-10 and CPT codes and et cetera. The 1500 form, the CMS 1500, and it used to be called, you may be familiar with HCFA 1500. That changed from HCFA to CMS 1500. This is a form that physicians utilize, private practice, rehab groups will utilize. It's also utilized for Medicare, Medicaid, fee-for-service. And we tend to think of paper when we're thinking of this, and hardly anyone uses paper. So the CMS 1500, electronically, it may be kind of that format that we utilize, and we'll kind of talk about that in a little bit. But that's the 1500 form, and who are the people that normally would utilize that, versus the UB04 billing form. It's put together by the National Uniform Billing Company, hospitals. So if you work for a hospital system, then you're going to bill under UB04. It's unlikely that you're probably going to work in some of the nurse facilities or inpatient facilities. There may be a few athletic trainers out there that are, but for the most part, the athletic trainers that would be most familiar with this would be the UB04. How the UB04 is different in that is that they follow and have revenue codes that they bill for. So athletic trainers have a revenue code, or there is a revenue code for other therapeutic services that is often used by athletic trainers. So that's explained in another billing course segment, but revenue codes are what's used versus the NPI number of the professional. What is probably the most standard utilized is the electronic format that's used, and it's an 837P for a professional, and for electronic submissions, which almost everything is electronically done in certainly the commercial market, and I would also say Medicare and Medicaid, then this format is what's utilized. And then finally, something that I did not really know a lot about this until I'd done some research and really worked a lot with some of the personal injury and workers' comp, but personal injury or PIP and work comp often will utilize just invoices. So if you're working with a personal injury, which would be an auto accident, and you're working with State Farm for somebody that has a musculoskeletal injury, and to do that, they may not have the system to be able to accept a CMS 1500 form or even electronically with that. They just want an invoice from you. So you have to make sure that you've got all the right information on that form to do that. And as I put on here, that's the number one reason to have that invoice or your bill rejected. Information that you really need, and this is kind of speaking specifically to the invoice, because all the other forms are going to have boxes to be able to fill all this information out so that you don't miss it. But if you're developing your own invoice, you have to make sure that you know that. And so, patient name, date of birth, referring physician. If there is any kind of pre-authorization number or documentation of that, really need to note that and document it. Need to, what was the date of the injury or illness? What's the ICD-10 or code or codes? So if there's multiple diagnoses with that. And then what are the treatment codes that were utilized? If you have different ICD-10 codes, you need to line up the CPT codes that are working with each ICD-10, because insurance companies will look at that and go, well, that treatment, that procedure makes no sense with that particular diagnosis. And this comes from the actuarial data that they've got. So make sure that you match up the appropriate treatments that you're doing with the diagnosis codes you've got as you list those out. As well, and kind of the last on here is, obviously you need to have your clinician or billing office. So, what's the name and address of the treating physician, the MPI number of the facility, if you're billing as a facility. If it's just you professionally, make sure that you've got your NPI as the clinician. And if you want to get paid, make sure, who should the payment be made out to and where to send it. So, as we're talking about ethics, we've tried to kind of talk about the coding aspects and what's appropriate to bill from the medically necessary standpoint and work through that. But from an ethical standpoint, how do you set your fee structure or fee schedule? How do you do that? We've already talked about that, financial considerations or preference, for either the patient or insurance company should not get in the way of the decision-making for the treatment or billing. Okay? As I bold here, staying neutral is a must. You're a treating clinician. You should treat whether this patient has insurance or not, no matter what insurance they've got, a great paying insurance, versus one that doesn't. The treatment for the diagnosis should be the same. From an ethical standpoint, a clinical standpoint, it should be the same. And so try to maintain that and do not let the financial aspects influence, what you're doing. What are some of the considerations for inappropriate charges for the services? Well, I've got a list here of, the kinds of service that you're providing, what's the difficulty or uniqueness of the service, time required, skill required for the service, what's your experience as an athletic trainer. So, should a new grad athletic trainer be billing the same as an athletic trainer with 15 or 20 years experience in doing that? In some situations, that answer is going to be yes, but that can be played into that. The quality of the athletic trainer's performance and market forces. Now, those are kind of the ideal things that we would put in. That's the idealistic aspects. How do we really set our fee schedules? And to do that, here are really three major ways that fee schedules are set up. The number one methodology for determining a fee schedule, and this is number one, insurance companies utilize it, health systems utilize this, physician practices, rehab groups, etc. And that is utilizing the Medicare physician fee schedule that CMS has developed. If you can imagine how much time, money, and effort that the government has put into rating procedures and determining the work values that goes into, and the expenses and the overhead and the qualifications of a practitioner to be able to do a procedure, they have done all of the mathematical calculations with that and rated every CPT procedure in the CPT code book. They've got that. And then they set a Medicare physician fee schedule for, and those are adjusted by geographic area, and that information is Everyone that is in the sound of my voice can get this information. It's on the web, and go out and research that. And for each individual code in your particular area, you can see what Medicare reimburses in that area for that. So what systems do, whether it's a practice, an individual practice, you as an athletic trainer, or a system or health systems, and even insurance companies, they take the work that CMS or Medicare has done with this, and then they utilize that, the math of that, and do a percentage of Medicare. So a lot of physician practices will take Medicare times 2. So if Medicare says for a therapeutic exercise that they will reimburse $45 for a 15-minute therapeutic exercise, you would take that, double that, and you would bill your fee schedule for that would be $90 for a 15-minute therapeutic exercise code. So again, that's hypothetical, just kind of throwing that out to see how that would work. So systems or practices or even individuals will get the information from their area that is, again, accessible to everyone, and then they will mathematically look at that. They'll either double it, they'll do a time and a half, they'll do time and a quarter, etc. No one that I'm aware of sets their fee schedule ever below Medicare rates. So it's some type of mathematical calculation off of the Medicare rates. And even work comp has started to do this. There was a time that work comp did not, but the last few years workers' compensation has started to do this. So that's the number one way of doing it. Second way that you can set your practice fee schedule is, really researching what are the market rates for your geographic area and the services provided. Now, this is difficult to do. It's difficult to get this information and that sort of thing. It is possible. There are some apps and et cetera, or some services that you can pay to join that you can get these market rates and that sort of thing. But this can be very time consuming and difficult to be able to put. It is important that you are within market rates of your geographic area, but then again, I point you back to number one, and Medicare is set up with that situation. The third way to set your fee schedule is to do an actual cost study of your practice. So you're going to look at your overhead and costs. You're going to determine what kind of profit margin that you want, and then you go across and you be able to set your fee schedule. Again, this is a way to do that. I don't know of anybody that is doing that, but that is something that you can consider to do. Some of the best practices as far as your fee schedule, and when we're talking about ethical practices, you set your fee schedule and you just find out that, oh my gosh, I missed the mark for whatever reason and how you did it. Well, you really should not increase more than 10% of that. Okay, that's going to really raise some red flags, to the payers, et cetera, if you're jumping that, and you really shouldn't do it more than every 6 months. So that's if you really missed the mark, you did it. Or you come into practice and you're the administrator and you find out that, wow, these pricing hasn't been adjusted for some time, and we need to make those adjustments. This would be a best practice. Certainly set your fees in consideration in the market. So do some research, and if you are in administration within practice, to look at that. You do or should have a uniform fee schedule for your athletic training rehabilitation. So have one fee schedule, no matter whether you're billing insurance, whether it's cash pay or that sort of thing. So the same fee. You can, and to the next point, you can provide discounts off of that fee schedule for certain classes. So the example that I would have here is that you have your set universal fee schedule that you've got. You're utilizing that. That's what you bill everyone. 100% of your patients, you bill everyone. However, for your cash patients, you have someone says, we're going to pay cash, then you will give your cash patients a 25% discount. Or some systems I know, physician practices will give a 50% discount for cash pay patients. So they will bill, let's say, the $100 for that, and then they will show on the invoice a cash discount at 50%, so amount owed would be $50. The most favored nation that I put on here is something probably you get into more with large groups and health systems and that sort of thing. When an Anthem Blue Cross Blue Shield or United Healthcare is negotiating rates, which are a large system, quite often they will plug into the contract a most favored nations clause that indicates that you then, the negotiator, can't go out and then set fees lower than what you've negotiated with Anthem Blue Cross Blue Shield. If you do, Anthem Blue Cross Blue Shield gets to lower their payment rates down to that level. So basically they're saying they're always going to be the most favored nation. You can never be able to negotiate with someone to accept less. And then finally, if you are doing contracts, whether that's contracts with insurance companies, et cetera, make sure that you have legal counsel that's really reviewed it and made sure that everything is good to go with that. Last thing I want to talk to you about is copay deductible coinsurance from a legal ethical standpoint. Professionals groups that are wanting to have in-network status are going to sign a contract with an insurance company, and that indicates that they are going to be considered by that insurance company as an in-network provider, and that is a contract with the provider, so between the provider and the insurance company. Almost 100%, I would say 100% of these contracts have language about collection of copay deductible coinsurance. It is fraudulent billing to write these off. You have a contract with the company to collect these. So this is especially important when we're talking about the collegiate setting or secondary schools, if you will. But I would say probably more collegiate, if you will, and especially Division I, Division II, in which over 85% of the student athletes, their entire health care is paid for by the university with that. If they are billing the student athletes primary care insurance, they are not balance billing any of the copay deductible coinsurance back to the student athlete parents or the owner of that. There are some circumstances where these can be waived. Hardship waiver can be, and that's the owner of the policy. So if it's the parents that own it, it's a hardship of the parents, not the student. If the student owns it, there very well may be more of a hardship aspect there. But hardship waiver, the NCAA Student Assistance Fund, so the SAF fund, can be utilized to pay for these fees and take care of that. And for universities that have a student health fee, these student health center fees often legally can be considered taking care of the copay for issues. So these are all exceptions that can be looked into. Now, if we're talking about out-of-network, so the in-network, you as a provider has signed a contract. You've got a contract with them. So you decide, well, fine, I'm just going to kind of get around copay deductible coinsurance because I'm not going to sign a contract with them. I'm just going to bill out of network, just going to accept what I'm paid and write the rest off. Well, I've listed some references here. I worked with a an attorney that was contracted by CSMI Sportswear to look into this, and so the attorney and myself were contracted to evaluate this. And this is, the attorney listed some of the things that I'm going to show you here in an out-of-network situation. You know, here where a person and entity intentionally interferes with the contract between two parties. So, and I'll let you go into that. But that's in an out-of-network situation. Also, you know, insurance fraud. If you have billed intentionally and know that it's false or misleading information, you know, that can be insurance fraud. So again, you're out of network, you're billing an insurance company $150, but you have no intention of collecting that. You are going to be happy if they pay you $75 and then you're going to write the rest off. Well, you knew it was false when you build it. It's misleading, and so that can be considered fraud as well. Common law fraud, you know, similar to this, a misrepresentation is made. You knew that. You knew when you billed it and went out that you were not expecting to get the full charge you paid for. So with all of these, with the copay deductible coinsurance, I am not an attorney. I do not pretend to be, so please understand that. I'm giving you some examples here, and I will give you some references here on the end in which you could be able to get more information about this. But always, if you're getting into the billing, whether it's a college, university, secondary school, practice situation, always have legal representation, go through your policy procedures, make sure and understand that and approve that. So that is their expertise. I know it costs money, but it's well worth the effort and money to do that. Here are some of the references that I've been mentioning, and they've all been footnoted, you know, throughout the talk. So please feel free to go out these. There's a lot of information on the NATA website, as you can see, to do that. You know, certainly with the HIPAA reference, AMA terminology, et cetera. And then number 6 there is the John Barry is the attorney referenced here that worked with on that. I leave you with a quote from John Wooden. You know, failure is not fatal, but failure to change might be. We need to, as athletic trainers, continue to push forward by trying new things, by getting into third-party reimbursement and et cetera. That's new territory. We're going to fail at times, but let's not fail because we're not seeking to do it correctly. We're not following the ethical guidelines the way we should. We're not following the law, et cetera. I want to believe that all of us that are doing this would have no intention of ever doing that. And it's very important for the profession as well as us individually that we do not. So with that, thank you so much for your attention to this presentation. It's been great to be with you. I hope that you have been able to pick up, you know, some different tidbits on some of the legal, ethical issues with billing third-party reimbursement by the athletic trainer. Thank you. Have a great day.